Dr. Harika. Today I will be presenting serodiagnosis of mosquito-borne infections in acute febrile illness cases. In recent years, the spread of vector-borne diseases has gained concern worldwide, especially in tropical and subtropical regions because of their shared endemicity and recurring outbreaks. The most common of these diseases includes dengue, chikungunya, and malaria spread by mosquito bites. And the cumulative burden of these infections has increased of late, with around 100 to 400 million cases of dengue occurring worldwide, and with chikungunya being over 2 million cases till date. Malaria, which has been estimated to have 229 million cases worldwide, also has 15 million cases in India alone. Apart from the shared endemicity, the three diseases also share similar clinical presentation with febrility as the most common symptom. Several studies have been published reporting co-circulation of malaria, dengue, and chikungunya. Simultaneous infections with more than one infectious agent complicate the diagnosis and course of the treatment available. Due to the similar nature of initial symptoms for malaria, dengue, and chikungunya, and overlapping endemicity, misdiagnosis of dual infection as monoinfection is a real possibility. These arthropod-borne diseases affect some of the poorest countries, and in resource-poor setting, clinicians may rely on symptoms and endemicity of diagnosis, which might lead to underdiagnosis of co-circulating pathogens. Any delay in either diagnosis or start of therapy for any of these infections could have fatal outcomes. Also, there is lack of sufficient information on how concurrent infections affect disease severity and outcome. The purpose of the study is to assess the prevalence of such infections. The aim of the study is to determine the serodiagnosis of mosquito-borne infections in acute febrile illness cases. And the objectives are to diagnose dengue, chikungunya, and malaria using appropriate serological tests and to determine the prevalence of co-infections. All age group patients admitted at the hospital with acute pyrexia and patients giving informed consent were included in the study, whereas patients with history of fever of more than 15 days and patients who are not giving consent were excluded from the study. This is a cross-sectional study conducted on patients of all age groups with acute febrile illness during January to July 2021 at Sir Ronald Ross Institute of Tropical and Communicable Diseases, Hyderabad. These are the materials and methods used in the study. 188 serum samples from pyrexia cases admitted at SRR, IT, and CD were collected and tested for dengue IgM antibody and dengue NS1 antigen using ELISA method. Chikungunya IgM antibody was detected using ELISA method as well, whereas malaria infection was detected using rapid detection tests. These are the results of my study. Of the 188 samples tested, dengue, chikungunya, or both were detected in 63 samples. That is 33.5% of the samples showed seropositivity. No malaria infections have been found in the tested samples. Out of these 63 seropositive cases, 38 cases were of dengue, of which 29 were positive by only dengue IgM, and 6 were positive for dengue NS1, and NS1 and IgM was positive in 3 samples. And 25 cases were positive for chikungunya IgM, whereas both dengue and chikungunya co-infections were found in 21 cases, that is 33% of the cases. This is a gender-wise distribution among positive cases. As you can see here, the dark green color shows the male population, whereas the lighter green shows the female population. In all the 3 diseases, there is a higher percentage of males. And among the 21 co-infection cases, 42.8% cases showed low platelet count, suggesting severe disease. Discussion. Dengue NS1 antigen occurs prior to the onset of symptoms and is detectable within 24 hours of onset of illness and may last till 18 days. Dengue IgM appears after 3rd day of febrile illness, peaks around 10 to 14 days, and generally persists for 2 to 6 months. Chikungunya IgM is detectable after 3 to 4 days after onset of symptoms and generally lasts for about 3 to 4 months. In the present study, cases of infections with dengue and chikungunya as well as their co-infections were found, whereas malaria infections were not found. This is the table showing seropositivity of dengue in various studies. In the present study, their seropositivity was around 60.3%, which was similar to studies done in 2017 and 2012, whereas Saswat et al. Done in Odisha in 2013 shows a lower seropositivity. This is a study table showing chikungunya IgM positivity in various studies. In the present study, the positivity was 39.6%, which was similar to another study done in Delhi, and whereas A study done in Delhi in 2014 showed higher seropositivity, and a study done in Orissa showed us lower seropositivity. This is a table showing dengue chikungunya co-infection rates. Here, the present study showed a co-infection rate of 33.3%, whereas which is similar to studies done in Delhi in 2014 and 16, which showed a seropositivity of 29.9% and 25.3% for the co-infections. Dengue and chikungunya co-infections were found in all age groups and genders. There was a male preponderance in the dengue chikungunya infections and as well as in co-infections. The severity of the disease was observed in cases of dengue and chikungunya co-infections. The present studies showed no infections of malaria in the patients admitted in the hospital. Several studies published co-infections with malaria, but the overall percentage of co-infections was low, which may be explained by the difference in transmitting vectors. To conclude, dengue, chikungunya, and malaria infections often affect the same population due to shared endemicity and mosquito vectors. Simultaneous testing for co-infections in endemic regions will improve diagnosis that will help in clinical management and taking of preventive measures.